It's live stream on YouTube.
Yes, sir. A very good evening and a warm welcome to all the doctors who have joined us today for yet another interesting session in the series of NEFFRON. To just set the context, I would like to inform that NEFFRON is an educational initiative by Saprin Formulations that involves the experts in the field of nephrology to share their practical knowledge and expertise in the chronic kidney disease management to the physicians. And we are very fortunate to have with us today as a clinical expert, Dr. Mahendra Mulani. Dr. Mahendra Mulani is a senior consultant at GCS Hospital and Shalby Hospital at Naroda. He is a director, Adya Women and Kidney Hospital at Bapu Nagar in Ahmedabad. He is attached with major hospitals of East Ahmedabad. He is a visiting consultant, kidney transplants at Narayana Hospital. He has managed more than 5,000 complex kidney patients and over 1,000 dialysis catheter insertion and more than 500 kidney biopsies. He has also managed 100 kidney transplant patients and more than 500 AV fistula surgery. He has expertise in managing pediatric nephrology, critical care nephrology patients, pregnancy-related kidney problems, geriatric nephrology, and has published many international journals and presented many papers on international conferences. So with this, I would like to welcome our clinical expert for today, Dr. Mahendra Bulani, sir, to address the audience. Thank you.
Thank you, madam, for nice introduction. And let me share my PPT. The host isn't allowing sharing for this meeting. I think you have to allow, madam, me to share.
Yes, sir, done.
Yeah, you able to see my PPT?
Yes, sir, it is just starting off. Yes, we can see your presentation.
Okay. So thank you for nice introduction, and we'll start with the today's topic: the need of alpha ketanoate in the management of the chronic kidney disease. So first, we'll describe about CKD prevalence. There are 850 million people affected worldwide. The burden of kidney failure is increasing in India with 210,000 new cases being diagnosed each year. CKD in India is often diagnosed late, reason being lack of awareness often play an important role, and the absence of symptoms. There is a higher incidence of interstitial nephritis and CKD of unknown origin contribute to the delay. Now, challenges with management of CKD are delay in the treatment due to the late diagnosis. There is a progressive nature of CKD due to leading to end-stage renal disease, malnutrition, and protein energy wasting. So, goal of treatment in CKD is mainly to prevent or slow further damage to the kidney, maintain overall health, reduce the toxins and nitrogen load, balancing the intake of energy, protein, sodium, potassium, and phosphorus with biological marker and weight changes. So dietary intervention is the mainstay approach of the CKD management. Now, introduction to the keto analogs. Keto analogs are amino acids. Keto analog of amino acids are nitrogen-free analog of essential amino acids. This lead to transaminase in the body to form the essential amino acids that lead to reduce the uremic toxins load, and it correct the amino acid deficiency and delay dialysis. So mechanism of action is transamination of essential amino acid. Alpha keto acids are converted into essential amino acid by transamination using available non-essential nitrogen source. So this process reduces the need for dietary protein intake while ensuring adequate protein synthesis. Now, reduction of nitrogenous waste. Unlike dietary protein, alpha ketanoids do not release additional nitrogen during metabolism. This reduces urea, ammonia, other nitrogenous waste and decreasing the workload on damaged kidney. So this is the picture of how the mechanism of action of alpha keto analog. Like this is the keto acid analog of essential amino acid. And naturally, this protein and amino acid metabolism that's generally create the nitrogenous waste product and other part converted into the energy, glucose, fat, and non-essential amino acid. Now, this nitrogenous waste product is used by alpha ketone analog, and with the help of vitamin B6, B7, folate, and B12, it's converted into the essential amino acid. That's further used for the formation of neurotransmitter hormones, growth of muscles, and other cellular process and enzymes. Other nitrogenous waste product get converted to urea, and that will get released from the kidney, and diseased kidney get accumulated in the body. Now, composition of alpha ketone analogs are alpha keto acids. These are the core of the medicine. Each alpha keto acids correspond to specific essential amino acid. Like example, alpha keto isocaproic acid is the alpha ketone analog of leucine. And calcium salt is often added to improve the stability and absorption of these alpha keto acids. This is this also contain essential amino acid. In addition to the keto acid, some formulation include the lysine, threonine, tryptophan, histidine, and tyrosine. So now need of double strength. Why there is a double strength is needed? Both strength contain the same essential amino acid, but double strength has a double dose of the same alpha ketone analog. And they both molecule caters to the different patient profile, dosage requirement, and compliance challenges. Now, single strength tablet is preferably used in CKD stage 3 to 4 with dietary protein restriction, elderly patient with the reduced dietary intake. While double strength is mainly used in advanced CKD stage 4 to 5 with rapid GFR decline, malnutrition post-transplant or post-cardiac surgery, patient with poor adherence to high tablet load. Now, dosage and administration recommendation dose is very high, like 1 tablet per 5 kg body weight. So, if you consider 60 kg ideal weight, so it's around 12 tablets per day. So, CKD stage 3 to 4, stable patient on low protein diet, around 0.6 to 0.8 gram per kg. Mainly elderly malnutrition patient, and it should be divided into the 3 doses, and it's given along meal to support the absorption. Always given with meal for transamination benefit, and combined with the dietitian supervised low protein diet. Double strength tablet, that is the 1 tablet per 10 kg body weight per day. So if 60 kg patient weight is there, then 6 tablet per day. Mainly used in CKD stage 4 to 5 advanced disease or low compliance post-transplant or post-surgical cachexia. So main benefit is low pill burden, half the number of tablet, and that should be administration with the meals. Now, overview of clinical benefit. It shows the slow progression to ESRD, reduce serum urea creatinine phosphate, improve serum albumin and nutritional marker, delay dialysis and improve quality of life in pre-dialysis patients. So these are the few clinical summary that supports the role of the alpha ketone analog. This first study Garneta, it's published in 2016, is the randomized control trial, and it's done on the 207 patient of stage 4 CKD. And they combine the keto alpha keto analog with very low protein diet, and they observe that there is a reduced need of initiation of dialysis, around 13% as compared to 42% in patient who was not taking the alpha keto analog. So there is the very significant difference. Another study Lorio in 2012 prospective cohort in 124 stage 3 to 5 CKD. They observed GFR decline is very slow in patient with the alpha keto analog as compared to the non-alpha keto analog patient. Now, another study published in 2009, multicentric longitudinal study that mainly done in the elderly CKD, and that also positive study and helped to maintain the serum albumin, prevent weight loss, and was well tolerated long term. KDOQ guideline also recommend in stage 3 to 4 CKD with the very low protein diet. And another study, Milovanova in 2008 observational study, they include 80 patients, and they observe that there is a reduced inflammatory marker, improved cardiometabolic marker, and beneficial in the high-risk patient. And another study on the diabetic nephropathy patient, they also observed there is a positive benefit. MDRD study group, 1994, RCT design, 840 patient, that is the very large study, and found benefit of low protein diet in CKD progression. Keto analogs used to support protein restriction without malnutrition. So key takeaway for the practice, effective in slowing CKD progression and delaying dialysis, helps reduce urea, creatinine, and phosphate levels, supports nutrition status without adding nitrogen load, backed by RCT and real-world study, recommended with low protein diet, 0.6 to 0.8 gram kg per day. And doses, single strength tablet, 1 tablet per 5 kg per day, and double strength if you are using 1 tablet per 10 kg per day. Always administered with the meal to enable transamination. Safe for use in elderly, diabetic, and high-risk CKD patients. Thank you. Do you have any questions?
Thank you so much, sir, for a very comprehensive yet crisp presentation. There are few of the questions that has come during the session that I would like you to address for all our audience who have joined us. So the first question is that at what stage of chronic kidney disease do you prefer to generally initiate the alpha keto analog therapy?
In my practice, I generally start after stage 3 CKD, stage 3 to stage 5 CKD. Once patient on dialysis, then I stop. But stage 2, stage 5 non-dialysis patient, it has a very proven benefit, and I personally observe that it actually prevent the further progression of CKD and also help to delay the dialysis.
Okay, sir. So the next question is, do you recommend alpha keto analog in diabetic CKD patients or elderly patients, especially who are suffering from malnutrition?
Yes, I think alpha ketanolog is recommended in each patient of CKD, whatever the either elderly, young patient, or whatever etiology of CKD, because it's actually help as an anti-inflammatory also and help to reduce the protein load, nitrogen load. So it's help in all type of CKD. So I do recommend the patient in all type of the CKD.
And sir, is there any biological marker, like, when to initiate the alpha keto analog in the therapy? What signs can a doctor notice before starting the keto analog therapy?
In practical scenario, we are not monitoring any biomarkers. We are just seeing the GFR. That is the main biomarker. We are seeing the creatinine body mass and we calculate the eGFR. That is the main biomarker we are using. Other biomarkers are on paper are there, but it's not practical because it is costly also. It's not easily available. So by the GFR criteria only and the etiology of CKD progression and the speed of GFR decline, that are the main factor that we consider before starting the alpha ketanalogs.
So, especially when it comes to India, like, you see a varied kind of patients. So, do you think dietary counseling is also essential when starting with the alpha keto analog therapy?
Yeah, it's very important because diet is a very important part of the CKD management because without diet restriction, just you are prescribing the drugs, that's not helpful at all. So we have to counsel patient for low protein diet, low phosphorus diet, low potassium diet. That is a very important component. Dietitian are always with us in all our patients. So I do prescribe diet prescription in all my patients.
Okay, sir. So, there's this one question. Have you used the double strength of keto analog before? And if yes, which kind of patient profile do you recommend?
Uh, Actually, madam, whatever I just we have seen in the slide, actual recommendation dose is very high, like 1 tablet per 5 kg, or if you are using double strength, then the uh, 6 tablet per day. But I don't think it's feasible in any type of patient because the 12 tablet per day or double strength big 6 tablet per day, it's also not possible. So in my practice, I generally use double strength in the 3 times per day. That is the maximum dose I am using. Main use is to reduce the burden of the tablets. Otherwise, single pill and double pill all both has the same benefit, but pill burden is reduced significantly, and that impact loss. And subsequently, I think cost also reduced with the double strength. So that is also beneficial. So these two factors. Otherwise, indication is same like GFR decline, stage 3 to stage 5 CKD. So in that one patient, we can consider alpha ketanolog either single strength or double strength.
Okay, sir. So, the main factor to consider is the pill burden in the patients.
Yes, madam.
Yes, sir. So, just a small message on the occasion of Organ Donation Day. Although it is beyond this topic, so just because it is a World Organ Donation Day, I would like you to share this general message to the doctors who have joined us today and also the patients who would be viewing on YouTube.
Yeah, so there are lots of myth about organ donation. Many people are not aware what is the actual use of that organ, because there are right now millions of people suffering from the end organ damage, and they are on the life-saving critical treatment like dialysis or many other organ like even liver failure patients. They are on the critical supports. So after dying, actually, there is a no use of organ for that person. That patient already going to die. So if we donate that organ can help in another patient to live a good quality life for another 5 to 10 years, maybe for long life. So that organ may alive in the patients for very long time, even if the donor may not be there, but their organ is alive in that person. So that is also actually very beneficial. And right now there are lots of waiting list patients, lots of patients are suffering. So I request all the relatives of the patients that you must register for your organ donation after the death. Yeah.
Thank you so much, sir. That was really a beautiful message to all the audience that have joined us today. So, with this, we come to an end of the session today. And I would like to thank you for taking your time and joining us for this session. And apart from this, for the audience, I would like to share that this recorded session is available on YouTube. You can share your comments or any questions that you have for Dr. Mahendra Mulani, sir, and we'll be happy to address the same. Thank you so much, sir, for joining us today.
Welcome.
Thanks a lot.